If you hear someone say, oh, that person has fatty breast tissue, that means that they've got a higher percentage of fat in the breast compared to glandular tissue. This would be our density categories, the first two categories. If you hear someone say, oh, that person has dense breast tissue, this means they have a higher percentage of glandular tissue in the breast compared to the fat. So these would be our last two density categories. And then honeycomb breast appearance. That's when a young person has really dense tissue and really anechoic milk ducts. And the anechoic milk ducts and the bright dense tissue, like in this picture here, looks like a honeycomb pattern. And we say usually for younger people just because that's when you tend to have the most density in the breast. All right, so axilla. Axilla means the entire armpit area, and this includes the axillary telospens, which is something we learned about last week. The axillary telospens is the region of glandular tissue where the upper outer quadrant of the breast glandular tissue extends into the axilla. We call that the axillary telospens. So this tissue normally in everybody extends into the axilla. So we should always see that in people. Where if they have accessory breast tissue is going to be that tissue found anywhere along the milk lines. And accessory tissue is going to be separate from this axillary telospens tissue. And why do we care that tissue extends into the axilla? Well, we care about that because since this glandular breast tissue extends slightly into the axilla, you can actually have pathology up there. So you can find a breast cancer up in this axillary tail region. So when you're evaluating this upper outer section of the breast, you should also always evaluate that axillary tail tissue because you don't want to miss a cancer that's in that section of breast tissue. Cooper's ligaments. These are the hyperechoic, or the bright white lines that course through the breast. They're ligaments, and they provide the structural framework of the breast. And then we have what we call the inframammary fold. This is down here. This is the lower edge of the breast. So it's infra, it's below, and mammary, breast. And they call it a fold because it's kind of where the abdomen and the breast meet. There's kind of a fold or a ridge there. And then the breast periphery. This is the outer edges of the breast tissue. So how do we annotate on a breast ultrasound? There's many methods. One of the most common is to split the breast into 4 quadrants. We have the upper outer quadrant, lower outer quadrant, lower inner quadrant, and upper inner quadrant. So the upper outer quadrant is always going to be on the upper and lateral sides of the breast. Upper inner quadrant always going to be towards the medial section of the breast and the superior portion of the breast. Lower inner quadrant, inferior and medial portions of the breast. And lower outer quadrant will be inferior and lateral sides of the breast. We also split the breast into a clock. So when we want to find, when we find a mass on an ultrasound, how do we get back to that mass later? How do we know where we were in the breast? So we've developed a clock system to help us map out things in the breast. We think of it kind of like GPS. So let's say I was scanning along in this left breast and I found something at the 2 o'clock position. If I put 2 o'clock on my images, I would know when I go back, I don't have to search through the whole left breast. I know it's going to be somewhere at this 2 o'clock position. So the top parts of both breasts is 12 o'clock. Bottom parts of both breasts is going to be 6 o'clock. Outer parts of the breast are going to have different clock positions because your clock always goes in the same direction. So on your right side, your outer part of the breast is going to be 9 o'clock. Your inner part of the breast is going to be 3 o'clock. On the left side, it's exactly the opposite. Your outer part of the breast is going to be 3 o'clock. Inner part of the breast is going to be 9 o'clock. We also use half hours, so 2:30, 3:30, 4:30, etc. We never use quarter hours. The next labeling method we use is called centimeters from nipple. This is our distance. So when we label a breast image with 2 o'clock because we found a mass at 2 o'clock, how do we know where at 2 o'clock it is? Is it 2 o'clock really close to the nipple? Is it 2 o'clock really far from the nipple? So this is a kind of a way to map things out to tell us where things are. Not really. Not so much in breast imaging, but the radiologists talk in those terms, so it's really important to know what they mean. Yeah. So here's our transducer. In breast imaging, we use the clock method, which breast it is, and then centimeters from nipple. And this tells us how far away it is. So in breast imaging, we use linear transducers, which means the top is flat. And linear transducers, a standard linear transducer is 5 centimeters across the top of it. This transducer is kind of a old one or specialty one. It's probably not quite 5 centimeters, but standard transducers nowadays are 5 centimeters across. And we use that as a ruler. So what we do is we find our mass in the breast. We have our nipple there. And let's say we have a mass that's here. So there's our mass. So we want to figure out how far away from the nipple our mass here is. So we use our transducer like a ruler. So if I think about this being 5 centimeters, we place it right up next to the nipple. And I can tell by this that it's more than 5 centimeters away from the nipple, if you guys can see that. So I know that it's going to be more than that. So I just keep using my ruler here. So I know that's 5. Here's another 5. So in this case, it's going to be about 12 centimeters from the nipple. So for this type of measurement, I'm simply using this as a ruler to tell me how far away from the nipple. So in this case, this mass would be 12 centimeters away from the nipple. Oops. Yep. Place your transducer right next to the nipple and you map out like a ruler. Because we don't carry rulers in our pocket, so and you just tell the patient, I'm mapping out where I am. Patients are like, okay. So how do we label this? We could say 12 centimeters from nipple. So that's one common way of annotating this. Some people like to say nipple plus 12. That means nipple plus 12 centimeters away from the nipple. Or some people break that down even simpler. N12, nipple 12. So those are 3 ways of annotating that same information. So when we're labeling the breast, the first thing we want to say is which breast. So we'll just say right or left breast. The second thing on our list is going to be the clock. The next thing on our list is going to be how far away from nipple. And it's always CM-FN, or one of those other 2 methods. FN, everybody in breast imaging knows that means from nipple. Those are standard things. And the next thing we're going to have is our transducer orientation. So are we radial or sag or whatever? So that's how we would annotate a breast image. Yes?
So when you're doing this though, like, are you saying 2 o'clock on the patient or like
Just like that.
Yeah. So it's like third.
Yep. Make sense? Okay. All right, so this is a outdated method of labeling, but again, on the ARDMS breast exams, you have to know it. But back in the day, and back in the day I mean probably about 15 to 20 years ago, they didn't have centimeters from nipple. They hadn't invented that yet. So they used to do this type of labeling. And every once in a while you might see this at a really rural breast center if you get outside images from them. So it's important to know what it means. But it's not a very accurate way of telling you where things are. Where centimeters from nipple, you can go right towards something if you have a clock position in a centimeters from nipple. But basically, we have the ABC labeling and the 1, 2, 3 labeling. ABC divides the breast into depths. So A would be a very superficial depth, meaning on the ultrasound it's very close to the skin. B would mean it's a mid-depth on the image. C is a posterior depth. And they would combine that with 1, 2, 3. So 1 would mean that they're splitting this breast into rings. 1 is the zone closest to the nipple. 2 is kind of midway between the nipple and the outer part of the breast. And then 3 is the outer part of the breast. So let's say I had this mass here, and it's pretty far away. 12 centimeters from the nipple is pretty far away. And let's say on my image it was kind of, let's just say it was superficial. So if I knew it was superficial, in this picture here I'm kind of, let's say midway between the depths. So this would be zone 2, and it's superficial, so it would be A. So when I did my labeling over here, instead of having my centimeters from nipple and radial, they would often say 2 o'clock. What did I write over? And they would say A2. So from that, I would be able to get in the right breast at 2 o'clock position, superficial depth on the ultrasound image, and it's in zone 2, meaning it's halfway between the nipple and the outer edges of the breast. All right, so planes. So when we're taking slices of information throughout the breast with our transducer, it's all about what plane are we in, what direction is the slice coming from. So common planes in all ultrasound imaging are sagittal and transverse. Sagittal means we're taking a vertical or up and down slices throughout the body. So when I've got my body here, or my breast here, I'm in a sagittal plane. I'm taking a up and down or vertical slice throughout the body. So my picture is taking my slice of loaf of bread this direction. When I go transverse, I'm now taking a horizontal slice through the body. And I like to think of transverse as horizon or flat, side to side. Vertical plane. For the breast, it would mean you're taking a vertical plane through the breast. So anywhere in the breast that you're in a traditional sagittal plane, which would be like this. Or transverse, you're in a horizontal plane. Yeah, we're going to go to that in just a sec. Yeah, no worries. You guys are good. So in breast imaging, we do occasionally use sagittal and transverse, but more commonly we use radial and anti-radial. Radial, why they developed radial and anti-radial is that radial plane follows the course of the milk ducts. Milk ducts radiate out from the nipple in a radial plane. And most pathology in the breast is milk duct related. So here's just kind of an example here. So here's a mass in the breast, and here they're taking all the different planes through this mass. So this is a radial plane, which shows the mass like that. Here is a anti-radial plane, which shows our mass like this. And then you've got your standard planes, which are transverse. Long is another word for sagittal, longitudinal. So here's your long. So here's your transverse and long. So when we do in the breast, when we find pathology, when we use sagittal and transverse, often it gives pathology that has a much more irregular appearance to it, very benign looking shapes. So that's why we've kind of gone away from sagittal and transverse in the breast. Do we still use them sometimes? Yes. But when we're scanning, we always, for the most part, want to stick to radial and anti-radial because this is the true nature of what these masses look like. And if we use a different plane, we can kind of miss the true features of a mass. So I like to think of radial as spokes of the sun. So a sun has rays that extend outward. So a radial would be a ray, like a ray of sunshine. And so anywhere in the breast that you're going, you're just going outward in a ray of sun. So as I'm going through this breast, you can see my transducer is really flipping around a lot because I'm following those rays of sun. So when we're imaging, we want the notch to always try to face the patient's right side or face the top of the patient. So as I'm going through, I'm trying to keep to that as much as possible. It gets tricky when you get over here. You kind of have to flip your transducer around and start going the other way. Yep. So we want to remember that our notch face the patient's right or face the patient's head. That's pretty much as closely as you can. Oh, we're going to learn that in a minute too. So anti-radial plane is exactly opposite to that. So anti-radial plane, if our ray of sunshine goes like this, there's my ray of sunshine, so I'm having my transducer go along that ray of sunshine. My anti-radial plane would be exactly opposite that. So I'm against my ray of sunshine, or ARAD. No, so think of a... Yeah, so it's exactly opposite. It's exactly 90 degrees orthogonal to that plane. So if I think of... I'm trying to find a pen that works here. Yeah, it's the same. Okay, so I have my breast. I have my nipple. So if I am in a radial plane, think of my rays of sunshine. This is where I'm going out in the breast, every direction. So my anti-radial plane is going to be exactly opposite that. That kind of thing. Yes, correct. So good observation. Do you start like the nipple and go like the line off each? Good question. So we're actually going to learn that next week in Scan Lab. But what we do is we divide the breast into a quadrant. And when we scan that quadrant, usually we scan it in radial and anti-radial. And I'm going to teach you guys how to do that actually next week. So in Scan Lab, you guys will learn that. So in some planes, these radial and anti-radial planes overlap with sagittal and transverse. So like say here at this more inner part of the breast, this is almost more like a sagittal plane even though it's also anti-radial. And this is almost like a transverse plane even though it's a radial plane. So there is some overlap with them. All right, so patient positioning. So we name a position based on what part of the body is touching the bed. So a right lateral decubitus position, this means that the patient's really steeply on their side and their right side is down. Or a right posterior oblique position would mean that the patient is up on their side but not quite so steep as a decubitus position, but their right side is down. We also use supine. Sometimes we use sitting up positions. And then the opposite is true. If the left side of the patient's body is touching the bed, this would be a left lateral decubitus. Left posterior oblique means there's the patient's a little bit less on the side. And we use this little pillow we call a wedge pillow to tell us where we are, or to position this patient in the way that we want. Okay, so we're going to take a break now. So take till about 7:30. Yeah.
So when it says like right lateral decubitus, it means the right part of the patient is touching the bed. And then when it's left posterior oblique, the left side is like on the bed. Okay, so whichever side is
touching the bed is what we call it. Yep.
I was trying to stay focused. Why it's so full? Like, it was, what?
See here. All right, ultrasound artifacts. So what an artifact is an echo on an ultrasound. This is a reflection that doesn't correspond to an actual structure in the body. So the sound wave goes into the body from our transducer, hits a structure, and it should bring a reflection or an echo back. But sometimes you get extra reflections that don't correspond to anything that create echoes on your ultrasound image. And this is an artifact. There's various reasons why artifacts occur, but they basically occur because an ultrasound machine, to produce an image, makes 7 assumptions about sound waves. And the assumptions are great assumptions. Many times these assumptions are true, but whenever these assumptions don't occur, an artifact is produced. Assumption 1, sound travels in a straight line, which is what we all would love to see. Unfortunately, sometimes it doesn't. So that's assumption 1. Assumption 2, sound travels into the tissue, encounters a structure, and then travels directly back to the transducer as an echo. Many times that happens. Does that always happen? No. Number 3, sound travels at a constant speed when it's in soft tissue, which is 1540 meters per second in soft tissue. Great when that happens. Doesn't always happen. And then also, echoes only arise from structures that are along the main ultrasound sound wave, or the main ultrasound beam that travels into the tissue, and not from the edges of the beam. Great when that happens, doesn't always happen. Also, another assumption is that the imaging plane is thin. A lot of people think a sound wave is flat. But a sound wave is not flat. It's got length and width and height to it. So the ultrasound machine assumes that a sound wave is really thin, and so that it can also produce artifacts. And then the amount of time it takes an echo to return to the transducer, the ultrasound machine times that and then says that, oh, the time it took, that tells me how deep that structure is in the breast, which is great, but that also goes back to sound traveling at a constant speed in soft tissue. That doesn't always happen. So sometimes the ultrasound machine, things are actually deeper or more shallow in the breast than they really are. And then sound attenuates at an even rate in the tissue. Attenuation is when a sound wave goes into the tissue, as it travels further and further and further and deeper into that tissue, it loses strength over time. And that's called attenuation. So these are the types of artifacts. We can have artifacts from the sound beam. This is where we assume that the sound beam is really thin. And these are the different types of artifacts we can get because of that. We can also get what we call multiple echo artifacts. This is where we're not just getting one echo back for each reflection coming back, but sometimes you get multiple ones back. We can get artifacts when we're using color and power and spectral Doppler. And we can get something called velocity error artifacts. And this is where your sound beam or your sound wave is not always traveling at a constant rate. And then attenuation artifacts, artifacts that occur because your sound wave is not losing strength at an even rate as it travels through the body. So the first category, ultrasound beam artifacts. These occur because of the 2 premises. So echoes only arise from structures within the main ultrasound beam, and the imaging plane is thin. So here is our ultrasound beam. And as we can see, it's got height, and it's got width, and it's got length. So by no means is this a straight, flat line. And so the ultrasound machine thinks that it's a straight flat line, and so because of that, it can produce these artifacts. So echoes can be captured from all of these sections of the beam where the ultrasound machine thinks it's just happening along this straight flat line. So types of ultrasound artifacts that occur, these are the types that can occur because of this. So here's the first one. Side lobes or grating lobes. And what happens is we have our main ultrasound sound wave or beam that goes out into the tissue, but we also have low energy beams that come out from the sides. We call these side lobes and grating lobes. And so when we're sending this sound wave out into the tissue and then a reflection comes back, you're also getting reflections from these low energy beams, even though they're weaker reflections. So echoes that return from the main beam, which are our stronger echoes, are going to be our normal or true echoes that actually came from structures in the breast. But echoes that came from these low energy beams generally aren't really necessarily bouncing off anything in particular. So echoes that return from these are going to be the artifactual echoes or extra echoes on a beam. And what this looks like on an ultrasound is you can have false echoes within structures. So a structure that should be completely anechoic, such as a cyst, which is anechoic or black inside, or the bladder, or the gallbladder, stuff like that, you're going to have echoes inside that image, making it less anechoic. And generally, these echoes are from these low energy beams. The next one is our Beamwidth Artifact. And this is related to lateral resolution. So an ultrasound beam, when it starts out, here's our transducer. The beam starts out as the same width as the transducer, and then it gets narrower and narrower till it reaches its narrowest point, and then it widely diverges. So when we're looking at structures along this beam, if we're right in the narrow part of the beam, we have two structures side by side, we could see those as two structures. But if these same two structures are at the same width and they're both within inside the beam, we'd only see this as one structure. So this is a type of artifact where we're missing echoes. We're not seeing necessarily all the echoes, depending on where in this sound beam we are. So this is why we like our sound beam to be really narrowed. And we narrow our sound beam on an ultrasound machine with the focus control, which is something we're going to practice with next week. So when we narrow our beam, we can see two distinct structures versus seeing only one structure. Slice thickness artifact. This is because our ultrasound beam is not flat. It has this third plane, the elevational plane or height of the beam. And so sound waves are not picked up just along a flat straight line, but also along the height of the beam you can have those low energy beams which can produce echoes. So you can also get artifactual echoes inside of a cyst. So here's our anechoic cyst. Here's our artifactual little tiny echoes that are inside this cyst, which should be completely black inside. And this is our slice thickness artifact. And these echoes, they don't correspond to actual structures. They're just artifact. Mm-hmm.
So when you're like
Mm-hmm.
like echoes like this,
Mm-hmm.
but they're not like any obstruction or anything. It's just like echoes.
Most of the time. Mm-hmm. Yep. Slice thickness artifact, or they're the side lobes and grating lobes artifact. Both of those do that. So pressing harder, changing our transducer plane, coming from a slightly different angle, adjusting our gain and our TGC and our focal zones, all of those are things we can do to eliminate artifacts. All right, the next category, multiple echo artifacts. These occur because they think that sound travels into the tissue, encounters a structure, and then travels directly back to the transducer. And also, the ultrasound machine times how long it takes the echo to go into the tissue and then return. And they think that's how deep a structure is in the body. But that assumes that an ultrasound beam is traveling at a constant rate, which doesn't always happen. So what really happens is you can get scattering in the tissue. There's strong reflectors in the breast and in the body, and these cause artifactual echoes. And the sound can bounce between different reflectors, which really results in extra echoes being on an ultrasound image. So this is the first type in this category, reverberation. So reverberation happens because there's a really strong reflector that's in the body. So in this case, this is a biopsy needle, which is this bright white line being placed into an area in the breast. And when the sound waves hit this biopsy needle, it's such a strong reflector for them that it causes the sound waves to start bouncing between the transducer and the biopsy needle. And what happens is, posterior to this biopsy needle, you start getting what we call reverberation. And reverberation is all these multiple lines of echoes. So the very first line is our biopsy needle. That's our real echo. But all these other lines posterior to it are not real. They're reverberation. They're artifact.